All right, thank you very much. Well, my lecture is about a 70-year-old hypertensive after acute stroke. Here are my disclosures. And we'll begin with the case presentation. We have a 70-year-old hypertensive man who arrived at the emergency department at 9:15 a.m. with speech difficulty and weakness on the right side. He had awakened that morning without symptoms, and during breakfast at about 8 a.m., his wife reported that the patient was unable to speak and could not move his right arm or leg. She called 911 and he was transported to the emergency department. The CT scan of the brain showed no hemorrhage and no early ischemic changes, and the blood pressure was 170 over 100 millimeters of mercury, and the platelet count, the glucose level, and prothrombin time were all normal. After the patient returned from imaging at about 10 a.m., a neurologist confirmed the presumptive diagnosis of acute ischemic stroke and recommended immediate initiation of intravenous thrombolytic therapy plus minus mechanical thrombectomy. In the management of blood pressure in patients with ischemic stroke, we have three settings: the pre-hospital management, the acute care, and the secondary prevention. I will start with the pre-hospital management, and the question that arises is, however, what about the pre-hospital blood pressure lowering? Is it good? Should we give some antihypertensive agent during the transfer of the patient from his home to a hospital? Well, we have about four major studies on that topic. We have the RIGHT and the RIGHT 2 that were done in 2013 and 2019. In these two studies, with antihypertensive agents, we checked the mortality and the disability at 3 months, and as you can see, there was no difference with the antihypertensive treatment. Also, there are another two studies with magnesium and lisinopril, and again, there was no difference with regard to functional outcome or mortality with the antihypertensive agents. So, from the European Stroke Organization, the guidelines from 2021, their recommendation is against routine blood pressure lowering in the pre-hospital setting. Also, the United States and the American Heart Association guidelines also agree on that and also recommend do not treat high blood pressure unless recommended in the pre-hospital management. Now let's move to the acute care of the patient with ischemic stroke. We have to consider patients not treated with not eligible actually to reperfusion therapies and those who are eligible. The first about the patients not eligible for reperfusion therapies is should we lower the blood pressure in the acute care of ischemic stroke? Well, we know from a lot of studies in the past that elevations in blood pressure higher than 140 and 160 millimeters of mercury are detected in about 80 and 60% respectively in patients with acute stroke. And it has been shown that both elevated and low blood pressure have been associated with poor outcome after stroke. And you see here at least 6 randomized studies that were done in the past: the VISTA, the CHIEFS, COSACs, the ENOS, SCAST, and CATIS, with several antihypertensive agents. And from these studies, all of these studies, none of these studies actually showed any significant benefit on cardiovascular endpoints or functional outcome by lowering blood pressure in the setting of acute ischemic stroke. On the contrary, early administration of antihypertensive treatment and actually the intensity of blood pressure lowering were associated with early deterioration, poor neurological outcome, or death. In a meta-analysis that was done by the European Stroke Organization in 2021 that included, with regard to mortality, 18 randomized trials in patients, again, as I said before, not treated with reperfusion therapies. As you can see, there was no difference in mortality, and also from the same meta-analysis with 12 trials there was no also difference in the disability of these patients at 3 and 6 months. So, what is the recommendation for the acute care in patients with ischemic stroke, but in patients not eligible for perfusion therapy? We all know that when the blood pressure is lower than 220 over 110, we should not give antihypertensive treatment to these patients for at least the first 24 hours, unless there is this is necessary for another specific comorbid conditions like aortic aneurysm or so. The same recommendation actually now you can see about 1 week ago on August 30. These guidelines of the European Society of Cardiology were published, and in European Heart Journal, and from their recommendation also, in patients with ischemic stroke not eligible for the perfusion treatment, but with blood pressure higher than 220 over 110, we can go very carefully and lower the blood pressure approximately by 15% during the first 24 hours after the onset of the stroke. Now, if we go to patients that are eligible for thrombolysis, we have a large meta-analysis here with more than 300,000 patients, of which about 1/4 received thrombolysis. And with regard to the outcomes with the blood pressure, the outcomes related to blood pressure, it was found there was a J or U-shaped relationship that you can see for the mortality, for the hospital mortality. All systolic blood pressure, the systolic blood pressure, mean arterial pressure, and pulse pressure were related to a J or U-shaped relationship. As expected from this meta-analysis, the risk of hemorrhagic complications of thrombolytic therapy was lower with lower systolic blood pressure and higher with higher systolic blood pressure. Another major study, a randomized control study that examined this if we have to lower the blood pressure in patients eligible for thrombolysis, was the ENCHANTED trial, in which two levels were tested. The intensive one with a target of systolic blood pressure 130 to 140, compared to the guideline recommended the target of lower than 180. And you see here that there was a mean difference in systolic blood pressure of about 7 millimeters of mercury. What was found from this study was that there was no significant difference in disability. And of course, as expected, again, there were fewer intracranial hemorrhages in the intensive group that had lower blood pressure. But from this study, in a post-hoc analysis of the ENCHANTED trial, it was found that the intensive blood pressure lowering significantly increased mortality at 3 months, despite, as we said before, that there was a significantly lower reported intracerebral hemorrhage. So, the recommendations for patients who are eligible for the perfusion, that we all know that during the thrombolysis, we should maintain the blood pressure at levels lower than 180 over 105 for the first 24 hours. And there is also a recommendation not to go too low, because from the ENCHANTED trial, as we said before, the patients for a target of 130 to 140 were at higher mortality compared to those that the blood pressure was lower than 180. How soon should we start antihypertensive treatment in patients with acute ischemic stroke? From the latest recommendations, as I said before, 2024, immediately for transient ischemic attack, and after several days after ischemic stroke. It is good that it's recommended that blood pressure lowering therapy should be initiated before hospital discharge. And now let's move to the third part, that is the secondary prevention of patients with ischemic stroke related to the blood pressure. From a lot of studies in the past. Also, we know that the annual risk of recurrence of a stroke is approximately 3 to 4%. We also know that a lot of placebo randomized controlled trials have shown that blood pressure lowering reduces the risk of recurrent stroke as well as cardiovascular events. And we know that antihypertensive treatment is effective because it results in reduction of 1 year recurrence risk by about 20 to 30%. The first meta-analysis on this topic was done back to 20 years ago, more than 20 years ago, with several randomized trials, including 15,000 patients. Here are the studies. You see that the known studies of Hopper progress, but also other studies were included in that meta-analysis. And from that first meta-analysis, it was found that there was about 24% reduction for the risk of recurrence of stroke, but also for myocardial infarction and other cardiovascular events. Another meta-analysis that was performed about 6 years later, also that actually included the PROFESS trial, also showed that there was a 22% reduction for recurrence of stroke. And in meta-analysis that was done from a Greek group, as you see, with 14 studies and more than 40,000 patients. From that study, you see the studies here. And from that meta-analysis as well, it was found that there was a reduction for the risk of recurrent stroke, for disabling or fatal stroke, and most importantly for cardiovascular death, cardiovascular mortality. Another meta-analysis was done by the European Stroke Organization 2 years ago. It was with 9 trials and a follow-up of 4.5 years. And again, it was found that antihypertensive treatment reduces recurrence of stroke by almost 20%. Also, a significant reduction in major adverse cardiovascular events and cardiovascular mortality. There were not sufficient data to allow analysis for the effect of treatment on dementia and functional outcome. You see here the 9 trials. It was 19, as I said, 19% risk reduction. And if we go to our question, so should we treat hypertension in patients after acute stroke? Of course, for recommendation with a high quality of evidence, stroke recommendation is that we should place the patients on antihypertensive treatment after an acute stroke, because we can reduce in that matter the risk of recurrence of the stroke, but also the cardiovascular events. Now, what are the blood pressure targets in the secondary stroke prevention? Should we go very low, lower than 130 to 80, or it should be not such intensive, the more conservative, let's say, approach. So from the same meta-analysis of the Greek group, that it was compared the intensive versus more conservative level of systolic blood pressure. It was found again that the more intensive systolic blood pressure had higher risk reduction for the strokes and the cardiovascular mortality. That was also true for the diastolic blood pressure, at least for the reduction of recurrence of stroke. And on this topic, also there were 3 major randomized controlled studies: the SPS3, the past blood pressure, and the PODCAST. Again, 2 levels were compared. The lower 120 to 130 compared to the less intensive 140 to 150. And from this analysis that was done by Cochrane, it was found that there was an about 20% reduction in the stroke risk. And the latest study from this matter was the RESPECT trial, in which when it was included in the prior meta-analysis session before, again, it was found that there was a 22 reduction. So the most recent guidelines from the European Society of Cardiology recommend a systolic blood pressure target of 120 to 130 after acute stroke. And if the patient has higher than 130 to 80, it is recommended to go for a target of 120 to 129, of course, provided that the treatment is well tolerated by the patient. With regard to which is the best antihypertensive agent, from the past we know that diuretics and diuretics plus RAS inhibitors were the best antihypertensive classes that were related to the major risk reduction for stroke. From the study of the group, the meta-analysis, as I said, from more than 4,000 patients, again, it was found that antiadrenergic beta blockers, calcium channel blockers, and RAS blockers were good, but not so good as it was thiazides and the combination of thiazides with RAS inhibitors. And the most recent guidelines also recommend that in the treatment strategy for preventing recurrent stroke, their recommendation is to place the patient on a RAS blocker plus a calcium channel blocker or a thiazide-like diuretic. The American guidelines also agree on that with the treatment of thiazide, and also, of course, they agree on shooting for a target blood pressure target of lower than 130 over 80. Of course, here it should be noted that it is important the blood pressure lowering magnitude for risk reduction and not the class of antihypertensive agent used. And reaching to the concluding remarks, in patients with a prior history of transient ischemic attack and ischemic stroke, blood pressure low treatment reduces the risk of any recurrent stroke by at least 20%, with greater reductions observed for intracerebral hemorrhage and lacunar strokes. Most guidelines recommend an intensive blood pressure target in patients with a prior history of stroke, using combination treatment, as I said, RAS inhibitors plus either a calcium channel blocker or a thiazide diuretic, and by initiating therapy immediately after TIA and within a few days after ischemic stroke. And finally, the intensive blood pressure control after stroke, the systolic blood pressure lower than 130, has been shown to result in a reduced risk of recurrent stroke by about 20-22% in the intensive treatment group. Of course, limitation to this recommendation could be for frail patients who are more sensitive to adverse effects of blood pressure lowering treatment. Thank you very much for your attention.